Time, I'll just start the session with Dr. Divya Alex. She is consultant in Ahilya Hospital, veterinary consultant, and will be talking on pathogenesis and classification of ROP. Over to you, Dr. Divya.
A warm good morning, everyone. I thank Dr. Anubosa and KSOS for giving me this excellent opportunity. So the born too soon babies or the early fighters, why is the subset of population so significant? Because preterm birth is the leading cause of neonatal mortality, and from an ophthalmic point of view, unfortunately, retinopathy of prematurity is the leading cause of preventable blindness in infants. It is preventable. That means if we act on time, we can save the vision. And our country, India, leads the top with 3.5 million preterm births. And this accounts for 26% of the neonatal death in the world, according to the UNICEF. So this resulted in strong political commitment, and India came with a new action plan, that is the India Newborn Action Plan. It aimed to end the preventable newborn blindness, deaths and stillbirths by 2030. A lot of newborn care NICUs were set up at the district level, but this was a double-edged success story. Since the launch of INAP in September 2014, the country has achieved remarkable progress in reducing newborn and infant mortality. In fact, from the 2014 to 2021, there was a 27% reduction in the neonatal mortality rate. But there was an unintended consequence. The babies who previously would not have survived started to survive. And the same infants were exposed or supposed to have exposed to supplemental oxygen therapy and prolonged intensive care. So this increased the ROP risk pool. And when the NICUs expanded rapidly, there was definitely a gap in the specialized ophthalmic care for ROP screening. So there was an increased incidence of the ROP owing to the wide variation in the neonatal care, and it is even found that more mature and heavier babies started developing ROP. So for this, we have to understand the normal retinal development. So in utero, there is a perfect environment for vasculogenesis. Vasculogenesis is the de novo formation of the primitive vascular network. And in utero, the metabolic demand always exceeds the oxygen supply, as there is always a physiological hypoxia that is maintained. And this physiological hypoxia will induce certain growth factors such as VEGF, the IGF, the hypoxic induced growth factor. This all causes angiogenesis. Angiogenesis, it is the growth of new capillaries from the pre-existing blood vessel. And this blood vessel will grow to the nasal ora serrata in 32 weeks and the temporal ora serrata by 40 weeks. But what happens in the preterm babies? So in the preterm babies, there is no longer the ambient uterine environment. So even the atmospheric oxygen will be a bit high for them. Then this period, the babies will be starting some respiratory distress. We will be pumping the babies with oxygen. So this oxygen, so instead of the physiological hypoxia what we need, there will be a pathological hyperoxia. So in response to that hyperoxia, the first response in utero will be the severe vasoconstriction. So in this vasoconstriction, there will be abrupt stoppage of the retinal vasculature. That means the retina is always sending a false alarm that we don't need oxygen anymore. So there will be abrupt stoppage of the growing vasculature. This is the phase 1. And after that, along the time, the babies will be showing some amount of improvement. The baby will stabilize. Then you pull off the ventilation and give room air or blended air. There will be a lot of oxygen fluctuation that is happening. And this stress will lead to oxygen reactive species, releasing lot of VEGF, hypoxic induced growth factor. But this time the VEGF is going to come back more than that of 100 times what was in utero. So this lead to the phase 2, that is the vasoproliferation. So there is a phase 1 when there is a VEGF downregulation and abrupt stoppage of retinal vasculature, and this is the phase 2, there is an upregulation of VEGF which is causing vasoproliferation. So you have to understand that ROP is a time-bound disease. It won't be present at birth, and between the phase 1 and phase 2 it takes 3 to 4 weeks. That is why we are keeping an ROP screening at 30 days of birth. So how exactly it progresses? There is a vascular retina and there is an avascular retina. So when there is a demarcation line happening between these two, vascular and avascular, we call it as stage 1. And when this line gets a height and width, that is called as a ridge, that is the stage 2. And when there is an extravascular proliferation into the vitreous or flat NV, stage 3, partial retinal detachment, stage 4, and when there is a complete retinal detachment, you call it as stage 5. So you trace the retinal vessels and you can see the abrupt emptying of the retinal vasculature. After that, it is a translucent zone. This zone, you call it as incomplete vascularization. There is no ROP, just that the vascularization is not complete. So this is your stage 1 of the demarcation line, stage 2 of the ridge, and stage 3 with the extraretinal neovascularization, stage 4A, the partial detachment, 4B, if the partial detachment is involving the fovea. And stage 5A, it is the open funnel where you can see the optic nerve head. Stage 5B, it is the closed funnel. And 5C, it is the closed funnel which is associated with anterior chamber findings such as AC shallowing, rubeosis, or iridocapsular adhesions. And first developed in 1984 and revisited in 2005, the ICROP has come with the 3rd edition. And why? Because the understanding of the ROP has changed. That is, now it is considered to be a worldwide problem. So what the low-income countries ROP might be having different pathologies from the standard literature. And obviously there are innovations in the ophthalmic imaging, and anti-VEGF treatment is also new. So this is the zone 1, that is the circle right at the center, the radius of which is that twice the distance between the center of the optic disc and center of the macula. And zone 2, from the periphery till the nasal ora serrata, this circle, and whatever the temporal crescent is remaining, this is the zone 3. So ICROP has come with a newer term, that is the posterior zone 2, that is 2-disc diopter from peripheral to the zone 1. So whatever disease in the zone 2 may behave more like zone 1. This posterior zone 2 should be considered as worrisome. And next terminology that has been introduced by ICROP is the notch, that is the incursion of this ROP lesion by 1 to 2 clock hours into a posterior zone. So earlier you would have called it as a zone 1 disease, but now it is zone 1 secondary to the notch. And defined in 1985, the plus disease was considered to be something that is vascular dilatation and tortuosity. Lot of confusions were there, but now it is considered as any abnormal looking vasculature in the zone 1, and this should be considered as a continuum, that is a progression of the disease. And the aggressive retinopathy of prematurity, now this is the term instead of APROP, and the hallmark of aggressive ROP is the rapid development of pathologic neovascularization and severe plus. And more than the location of the disease, the important features are the tempo and the appearance of vascular abnormalities. So there will be vascular looping with severe plus, and there is an ill-defined junction usually between the vascular and avascular retina, which we call as the deceptive featureless junction. And this is mostly considered to be an oxygen-induced retinopathy. So screening will be dealt beautifully by Anubhav sir, but always remember the code of 1, 2, 3, 4. And to conclude, ROP is a time-bound dynamic disease, and we have got only a small window of opportunity for effective management. And as our country tops the number of preterm birth, there should be increased awareness of ROP, and remember that every single blind kid will be a tragedy. So thank you, sir.
Thank you, Divya, for a very elaborative explanation of pathogenesis, which is very important. So